so much, Joseph sir, for this wonderful talk. Next sessions would be on diabetic hypertension, which will be chaired by Dr. V.S. Hariharan sir, DNB, Internal Medicine, MRCP UK, Senior Consultant Physician, Global Health City, Chennai. And we'll have Professor P. Paranthaman, MD, General Medicine, Professor and Head of Department of General Medicine, Kilpack Medical College. He'll be talking about hypertension in young adults. Small change, Sudhakaran sir will be chairing this session.
Very good afternoon to all. Just I'm standing between you and the lunch. I think most of you has gone for the lunch. It is easy for me to finish off my talk in 10 minutes instead of 20 minutes. Nice. Thank you very much for the wonderful opportunity. And I'll be talking about the most common. So far we are listening to the advanced technology, TAVI, TVR, and double stent, two stent, drug-eluting stent, and now has gone to the basics of medicine, what you learn in the first clinical MBBS. So, hypertension in young, how to go about it? Slide. The prevalence, why the hypertension in young? What is young? When you say hypertension, generally middle-aged, elderly, it constitutes primarily a primary hypertension. That means essential hypertension. That means we do not know the cause. But hypertension in young means something you have to think, something is there. That means you are missing out the secondary hypertension if you don't look into it properly. So, when you say hypertension, it's like measuring a CBG, glucose. Go to the office, take on CBG, capillary blood glucose, say it's elevated. Go next day, it is normal. Similar to that, the hypertension anytime may be high, anytime may be low. Before you start medication, you should make sure he is having persistent hypertension to be treated, or just white coat hypertension, it should not be treated. You may be missing masked hypertension. So the goal is to accurate measurement of blood pressure. When you say measurement of blood pressure, you see what conventionally is that, what is conventional is that we do conventional method. Whenever you have blood pressure, you take at least 2 to 3 times in the clinical visit. Then make sure that blood pressure is consistently elevated, then start antihypertensive. Now later came the automated blood pressure monitoring, where that machine itself measures 3 times when you tie a cuff, and that will give the average value of 3 minutes. Now they came that no, that is not sufficient. 3 times value is not sufficient. You take a home blood pressure, confirm it, it's really elevated. Then most of the time we do not know how to advise for home blood pressure monitoring. You have to at least 3 times in the morning, 3 times in the evening, at least 4 days before a confirmation, and remove the first day and take the 3 days average values, then you make sure the patient is having high blood pressure. And then no, that is also not sufficient. Now go for ambulatory blood pressure, where whether patient is sleeping, lying down, working, not working. So all the time, at least 24 to 40 hours, you measure blood pressure, take an average, make sure the patient is having hypertension, you treat it. Then sometimes we know what value you treat, what is the normal blood pressure, what is the normal pressure in the morning hours is the same as the night hours. Morning, it's anything more than 130 by 135 by 85 is abnormal. But the night time, normal blood pressure is less than 110. If it less than, normal it is less than 110 by 65. It is not 130/85. So that average value should be applied. So the white coat hypertension is very common, especially young, because of sympathetic overactivity. The moment you come to a doctor, the sympathetic surge, your blood pressure is 220 by 170. Sometimes I may hesitate to write the 170 as a diastolic blood pressure, what I measured in my clinic. Because if you give 10 minutes of time or 20 minutes of time, you come and take the blood pressure 170, 100, another 20 minutes later maybe 130, 70. That is the scenario what we see. So there is no end organ damage there, that's what hypertension. Something called masked hypertension. So whenever a patient comes to us, always the blood pressure is normal. You won't be treating the patient. But he goes home or go to the office, blood pressure elevated. How to identify that? That's ambulatory blood pressure monitoring helps. And this is very common in diabetics, elderly, and of course CKD patients. And what is the goal too? Goal 2 is to identify the cardiovascular risk. Why are you interested in hypertension? Is there any complications secondary to hypertension? Like stroke, MI, PVD, CKD, what are the things? So assess the cardiovascular MI with the basic measures, and then most importantly in diabetic hypertension should be identify the treatable cause of secondary hypertension. The secondary hypertension is the one very dangerous. Suddenly this is a refractory hypertension. Anyone comes with the refractory hypertension, resistant hypertension, think of secondary hypertension. Anyone who is having increased rate of hypertension, continuously persistently elevated, not controlled, think of hypertension, secondary hypertension. But fortunately the secondary hypertension is treatable. It's a curable if you identify it early. And they say that this symposium, the whole conference based on diabetes and hypertension. What is diabetes and hypertension? How can the diabetes produce hypertension? Diabetes is blood glucose. How it produces hypertension? The hypertension is the one, how it produces diabetes. Yes, there is a mechanism. Before the onset of diabetes, you know that hyperinsulinemia starts before 1 decade before the diagnosis of diabetes. After 1 decade of diabetes, hypertension develops. See, 1 decade before hyperinsulinemia, 1 decade after you have hypertension, albuminuria, and after that subsequently you develop CKD. So CKD may lead to hypertension, hypertension lead to CKD, CKD to diabetes, diabetes to hypertension, both are interlinked. So that's the mechanism of hypertension, because the most important factor in diabetes causing hypertension is AGE, advanced glycogen product, angiotensin 2, endothelin, and this are secondary growth factor. So these are the substance essential or which makes a patient develop hypertension because of the increased excess expression of these hormones in diabetes, resulting in hypertension, and hypertension resulting in kidney disease, and kidney disease leads to hypertension. So that's the mechanism goes on. Then we go to hypertension young. See, whatever we talk, diabetes resulting into all the complications. So nowadays the primary hypertension, the second hypertension more in younger individuals than the primary hypertension because of the lifestyle changes, obesity, diabetes, hypertension, cholesterolemia, and all these lifestyle changes. So if you go to the causes of hypertension, the second hypertension, the renal cause is a primarily renal cause. Maybe renal cause may be renal parenchymal cause, maybe renal vascular cause, or renal tumor in the cortex that may be leading to all the causes, and sometimes maybe to vascular causes. And it may be due to neurogenic cause of hypertension. Like you have this acute spinal cord injury, you can have hypertension young, so like psychogenic. And miscellaneous cause like endocrine cause, hypothyroidism, and hypercalcemia, all this can cause. Then most commonly secondary hypertension young is drug induced, NSAID, and of course excessive drug induced. And the most common in hypertension in secondary hypertension is in the young is renal hypertension, renal parenchymal hypertension. That is 85% of the CKD patients will have hypertension. It is hypertension secondary to volume overload. So treatment should be decrease the volume, either diuretic or measures to restrict the thing. That's the treatment ends there. And it is confirmed, all confirmed by the creatinine elevation or the biomarkers, all that there, and spot urine protein is early to be used to identify renal parenchymal injury. The second one is the primary hyperaldosteronism. Aldosteronism is what? It's the most common reversible cause of hypertension. If you identify it early, it is common in younger individual, in a male, come with hypertension, anxious, then unprovoked hypokalemia. If any person, younger individual, comes with hypertension, unprovoked hypokalemia, you can diagnose it as a primary aldosteronism. You have not done any test except potassium. Just look into potassium. That's why that is mandatory to look into electrolytes in a young patients for the electrolytes to identify the cause. So even before the MRI, CT scan identifies is a primary hyperaldosteronism, you just identify with the only potassium in a young male with a second reversible cause is this. The renovascular hypertension. Renovascular, again, yet another common condition where renovascular hypertension may be the distal problem or proximal problem, or proximal artery osteal stenosis is more common in elderly. So elderly male comes with hypertension, sudden increase in blood pressure, resistant hypertension, think of renal vascular hypertension, especially atherosclerotic induced proximal congestion. So proximal stenosis of renal artery can be diagnosed clinically. Whereas a young female comes with hypertension, asymmetry in the kidney more than 1.5 centimeter different, then we saw this dysplasia, renal vascular dysplasia. So the renal vascular hypertension also clinically you can diagnose. So that can be with the unilateral kidney. That's the size of the kidney. So asymmetrical kidney is there. And this is a distal one, and proximal occlusion, proximal stenosis is atherosclerotic, distal one is dysplasia. Yet another common condition in young is that pheochromocytoma. Pheochromocytoma, unless you have a clinical suspicion, you will miss it. See, patient comes young male, person with there is a pounding headache, severe headache with sweating, palpitation, and paroxysm of blood pressure, sometimes low, sometimes high. The young male, think of, then you abdominal examination, you can feel the mass. The mass is big one in pheochromocytoma, whereas mass is small in Conn syndrome, like hyperaldosteronism. So you are a clinician, you are making diagnosis of hyperaldosteronism or pheochromocytoma clinically, nothing else, no parameters, liver parameters are done or the blood parameters are done. So you see this a mass, sometimes paraganglioma may be there. If you see the sensitivity of the test, what the sensitivity we have, that urinary the metanephrine levels and fraction metanephrine levels, and that's very sensitive than the serum cortisol level and serum levels of metanephrines. And also imaging, now we have wonderful imaging, CT scan, MRI, and MIBG scan is there to look into the area and what size of the tumor, and you can identify it early and treat the patient. And one another important is that coarctation of aorta. It's very common in children and young adult, not the elder adult. Children and adolescent age, anyone comes with hypertension, think of coarctation of aorta. Just look at the pulse in the both upper limbs and lower limb. You see the lower limb pulse is weak, upper limb pressure is high, as well as pulse volume is good. There you make a diagnosis of a coarctation of aorta. No investigation is required to make a diagnosis, but you can confirm your diagnosis by your angio and for other investigations. The Cushing syndrome. Again, Cushing syndrome is common. Unless you have high index of suspicion, you will not look into it. Then they present with the typical Cushing's feature, like central obesity and all sort of the moon face and this lemon the onion appearance is there. The laboratory investigations, what you look into is the increased serum cortisol level. Of course, increase serum cortisol levels, but you do the suppression test, dexamethasone suppression test. You do 1 milligram dexamethasone at 11 o'clock in the PM and measure the fasting at 8 a.m. Steroid level. If it's more than 50 nanomoles, it is Cushing's. And if you can have high dose dexamethasone suppression also, they give 2 milligram every 6 hours for 48 hours and see there is no suppression again there. Sometimes if you are not able to do that, you can go for salivary cortisol also, that helps in making diagnosis of Cushing syndrome. And if that is not there, they can go for the higher level, corticotropin releasing hormone that is there, and maybe ACH dependent, ACH independent. If ACH is dependent, you do MRI. If ACTH is independent, you do CT abdomen. So you specifically target your investigation depends on the patient, so not much of expenditure is you put to make a diagnosis. So maybe ACTH independent or dependent. And yet another problem in younger individual is that thyroid disorder, maybe hyperthyroidism or hypothyroidism. When hyperthyroidism, you have systolic hypertension, hypothyroidism, you have diastolic hypertension. So you look into it, which is high, and is the clinical situation warrants, then immediately look into it, then you will identify. You need not do other tests to rule out second hypertension, just go by simple clinical parameters and the thyroid profile, you will say it is hypertension is due to hyperthyroidism or low thyroidism. Yet another common condition is sleep apnea syndrome. This is because of the increasing epidemics of obesity we will have, and this will have typical feature of a nocturnal the apneic index is be increased. The apnea hypopnea index is more than 15. You can confirm by the polysonography, and of course clinically also history of snoring and daytime somnolence, tiredness, and poor concentration. You can simply make a diagnosis of this sleep apnea syndrome clinically. And of course, these are the clinical tests you can go by, the observations. for all the clinical make a clinical diagnosis, you look into the all clinical features, like so if you see abdominal brie, renal vascular. If you have absent pulse, it is coarctation aorta. If you have acne, it is Cushing syndrome. If you have mass, abdominal mass with hypertension paroxysm, it is the pheochromocytoma. Similarly, all other conditions will have its own clinical points to make a clinical diagnosis. Laboratory investigations, again you go by the urinary level, cortisol level, urine, all that depends on your clinical suspicion. You screen into that particular test and you can identify it. So treatment algorithm management for hypertension is that you look into it whether the patient is having diabetes or not. So when you choose antihypertensive drug, you look into it whether the patient is hypertensive with the diabetes or without diabetes. If it is a diabetes, the step 1, step 2, step 3, step 4. Step 1, ACE inhibitors or ARB. Why ACE inhibitors ARB? Because increase the expression of ACE2 enzymes and receptors there, so thereby it causes all the damages, and thereby that's the first line of treatment in all diabetic individuals if no contraindication. That's step 1. If you're not able to control, you can add a CCB or thiazide. Right? Again, if it is not able to control, then you go for addition of 3 drugs, AC, ARB or CC with thiazide group of diuretic or diuretic. If that is also not able to control, then you can add mineralocorticoid antagonist or alpha blocker and also beta blocker if the potassium is more than 4.5 millimoles per liter. So that is for diabetics. If it is a person without diabetes, less than 50 years, 55 years or more than 55 years. Less than 50 years, treat them with diabetes. More than 50 years, then you go, instead of ACE inhibitors in the ARB, go for CCB, calcium channel blockers, either non-dihydropiridine or dihydropiridine, depends, probably dihydropiridine will be more appropriate, and if it is not able to control, you can add ACE inhibitors in the ARB or thiazide diuretic, then add one more drug. Probably if it is again not controlled, you can add mineralocorticoid antagonist or alpha blocker and this thing. If that is also not able to control, then go for a specific therapy. Interventions are lot of interventions available. You can refer the patient for interventions. So friends, the conclusion is the evaluating secondary hypertension is very costly because we have to rule out all the conditions what I mentioned, and in more than that there are so many other conditions which is not mentioned. Very difficult. But use a simple clinical examination, clinical application of signs and symptoms. With that you can make the diagnosis of primary or secondary. If you are secondary, very appropriately do this test and confirm the diagnosis, do appropriate intervention and prevent a complication and death. So clinical examination, history and examination is sufficient to make sufficiently confirm the diagnosis. With a simple test available, you can prevent a complication and death. Thank you very much for patient listening.
So thank you, sir, for the wonderful talk. I think you made it look so simple. Any questions from the audience? I think, sir, you highlighted the basic clinical signs are very much important in the daily practice, and we see a lot of people missing these and then people landing up with complications. It was a great talk, sir, and thanks for putting up a great scientific program as well. Thank you so much, sir.
Thank you very much.
Dr. Professor Paranthaman, sir, for the speech. Now, we'll take a break for lunch. We'll assemble here at 2 o'clock.
Came out which show